Good day, my dear postgraduate students. Welcome to R.A.T.S in Pathology. The topic for the day is synovial biopsy. Any biopsy or its interpretation is a different type of a question which shall be answered well only if prepared properly. One of my major references is Ackerman. The other references are quoted within the presentation. Think of the subheading. The subheading will take you to the answer. Here we are seeing a series of subheadings which can be altered, which you wish so. Also, kindly notice that there is a reference on the screen, which might be visited if time permits. This is a structure of a joint, which is nothing but an articulation between two bones. The bone itself is covered by a cartilaginous cap, and it has in turn got a pericartilaginous connective tissue. On the lateral side, I find the synovium, which secretes a fluid called the synovial fluid. The function of this fluid is 1. Nutrition, 2. Lubrication, and 3. Shock absorption. This we shall rapidly go through because it will be mandatory for you to mention it, even though the question is synovial biopsy. Just like any other fluid, you have got the various components such as the appearance, clarity, viscosity, cells, and examples. And it can be divided into non-inflammatory and inflammatory. Inflammatory itself being non-specific or septic, and then a hemorrhagic or a hemarthrosis. The various components are given over here along with the classical examples which you people shall go through. Arthroscopy is a modern procedure. In fact, it has become mandatory in today's walk of life. It is minimally invasive. Biopsies can be performed by this. It can be used for reconstruction, minimal trauma to the connective tissue within. A small incision alone is needed. Saline irrigation is mandatory for asepsis. Tissues such as tendons, meniscus, or even the major joints can be reconstructed or operated upon. One of the drawbacks can be chondrolysis, which is minimal. So we generally have an illusion that it is a highly septic procedure, which is not so. When you take a biopsy of the synovium, there are two types. I would like you people to kindly by heart this. One is an arthroscopic biopsy and another is a closed needle biopsy. For an arthroscopy, a specialist will be needed, whereas here it is a bedside procedure. Light and irrigation are required. It is a blind procedure, not required. Targeted sampling of the abnormal tissue. This is a blind procedure again. There is a high diagnostic yield. There is a lower diagnostic yield. The cartilage and the other structures can be visualized, which is not possible. Obviously, the cost is more, lower over here. More time consumed, lesser time, and anthrocentesis can be performed, not so over here. This is a specialist and a training is required for it. This probably some meticulous method will be sufficient. I would like you people to kindly read up this so that you have a basic idea. Any of the pathology questions, we should have a clinical and an advanced backup. Understanding a joint. As mentioned earlier, there are a couple of bones, there is a cartilaginous cap. And this is our friend, the synovium. The synovial cavity having the synovial fluid. But what is important over here is another component, namely the bursa. Bursa and synovium are not the same, but sometimes there can be a connection and a similar lining. Otherwise, a bursa is lined by flattened cells or not even so. That is what we see in a bursal cyst. This particular slide is of paramount importance, indicating the applications of a synovial biopsy. Even I was of the opinion that histology alone will be of great importance. But then, please have a look at it. There can be an analysis of the proteins. There can be a biochemical analysis as well. But then, even other procedures such as Western blot can be performed on it. Transcription can be done, whether it is for single gene or multiple genes. There can be a whole transcriptome that can be delivered from it. Coding regions and the non-coding regions can be studied. So this is the genetic counterpart of it. In between, we have got the in situ hybridization. Immunohistochemistry can be performed in the tissue, so it is of great importance, particularly when there is a diagnostic difficulty. So look again over here. It is not this space that is the synovium. It is a lateral space that is the synovium from where the biopsy is taken. Please compile an entire list of yours, which is again shown later on for your benefit. One of the important diseases that is associated with the synovium shall be the osteoarthritis. Osteoarthritis, it is basically a misnomer. It is considered to be an inflammation of the joint, whereas it is actually a degenerative disorder. There is a fibrillary degeneration of the joints. There is a roughening and thinning of the cartilage. There can be cartilaginous or bony spurs which are delivered into the cavity. The capsule is stretched and the synovium will be showing reactive changes such as inflammation, thickening, and so on. Sometimes there can be papillary projections which can be made out by CT. Also, the cartilage can be undergoing osseous metaplasia or the connective tissue can be undergoing cartilaginous metaplasia. So this particular picture is a revision of the same. I would like you people to go through each of the pictures rapidly. I am not going to repeat this one. So also this side. It is supposed to be normal, composed of the bone, the cartilage, the synovial fluid, the membrane. Whereas on this side, in osteoarthritis, there is a thickening of the external capsule, there is an inflammation of the membrane, there is a degeneration of the cartilage with loose bodies, and sometimes there can be bony projections or osteophytes. So please do remember, it is not an inflammatory disorder, but a degenerative disorder. This is of paramount importance, namely the rheumatoid arthritis. Again, on one side, I am seeing the normal tissue. And these are the cartilages the chondrocytes can be used for culture. On the other hand, there is an erosion. There is a formation of a pannus. What is a pannus? I shall be explaining. There is a hyperplasia of the synovial membrane. And here it is encroaching into the joint space. That is where we find. There is a fibrinoid degeneration, granulation tissue, and sometimes there can be a fusion. All these constitute what is called a pannus. Look at this for example. The synovium is flattened and to the side. But here I am finding that there is a hyperplasia of the lining membrane. Also, there can be papillary projections into the joint space. The subsynovial tissue or the synoviocytes are undermined by lymphocytes, plasma cells, and sometimes I will be able to see aggregates of lymphocytes, if not follicle formation. Rheumatoid arthritis commonly affects the small joints, more common in females, and there is a synovial proliferation, papillary projections, plasma as well as lymphocytes. Plasma cell is important because it is an immunological disorder. Also, the capillaries will be lined by plump endothelial cells, which is supposed to be one of the diagnostic features. There is a granulation tissue, fibrillary degeneration, matrix, all of which together form the pannus. Also, the underlying bone can be showing osteoporosis. This is another series of disorders, which we will have to mention for the sake of completion, though not a routine visitor of ours. Neuropathic arthropathy and Charcot's joint. So these are again degenerative joint diseases. The synovial membrane is only secondarily affected. There will be hyperemia. Dead bone or cartilage can be released into the joint space, which is again immersed in the connective tissue. That is what you people are seeing. These are the loose cartilaginous spaces and malaligned bony tissue. Here again, I am able to see that there is a degeneration and the release of this chondrocytes or cartilaginous spicules in and around the tissue as well as into the joint space. Giant cells are commonly seen. A word of warning. We can find different types of giant cells as foreign body type of giant cells, the classical Langerhans type of giant cell, sometimes the two-tone giant cells. In the case of a xanthoma, all should be borne in mind because all giant cells do not indicate tuberculosis. Now, what are we seeing on the screen? A joint has been opened up and it is not homogeneous or hemorrhagic. Instead, I find that there are some loose bodies within the joint space. These are called rice bodies as such. Look at this picture also. Or some people describe it as watermelon seeds. These are classically seen in tuberculosis, but not always definitively so. So the granuloma with the Langerhans type of giant cells is seen over here. For the sake of this, you are able to see multiple detached bony fragments within the joint space and being released from the wrist also. There are multiple rice bodies that are being seen. This is yet another specimen showing that and the granulomata with the giant cells. Gout, another friend of ours. A gouty tophus affects the small joints of the hands and feet. Usually a solitary joint is affected, maybe a few more. And in this, there is the classical gouty tophus. Tophus again is an acellular precipitate that is being formed, and around it, obviously, there will be the foreign body type of giant cell reaction. Though this is not an ideal example for a synovial biopsy, for completion, we will have to mention this. And you find that the aspirate or the delivered fluid will be showing the uric acid crystals, which again is seen in these pictures. So the tophus over here along with the giant cells, and these are being released into the joint spaces, which can be having the needle-shaped crystals. So just for the sake of recapitulation, I shall be revisiting this repeatedly. These kind of line diagrams you people should draw in your answers. But this is exactly what I wanted to show you people. In this one, you find that there is a cartilaginous cap, the black one, but there will be a small area where it does not cover the bone. This is called the bare area of the bone. So what shall happen will be, it will be prone for infection and trauma. So again, the normal structures I will not be going into, but what is there in this picture? There is a normal synovium. It contains a few T cells and it leads to inflammation because of the accumulation of TRM. It remains in the synovium, and activation of the TRM, it triggers a continuous and a recurrent cause of joint injury. Now, what is TRM? Tissue resident memory cells. It is only because of this memory that some diseases become perennial. This is again a pathogenesis of the rheumatoid arthritis, not indicated in the question of synovial biopsy, but it is a wonderful diagram which I would like you people to go through and draw in your answer on rheumatoid arthritis or otherwise. The normal structures are mentioned over here. There is a hyperplasia of the synovium and it grows over the cartilage over here. There is also a vascular release of the various mediators that are over here, including the prostaglandin. There is a decrease in the proteoglycan, resorption of bone is there, and enzymes such as collagenase cause a degeneration, leading to the formation of the rheumatoid pannus. And these are the various cells which can be activated and the mediators that they release. CSF, for example, is colony stimulating factor. Always mediators of inflammation, have it in one corner of your mind. And this again indicating the bare area. What are all the changes you people will be seeing? Rheumatoid arthritis, it is an immune complex disease. It can be polyarticular. Synovium will be showing hyperemia initially. Lymphocytes, plasma cells, and follicles can be seen. There can be something called as synovial giant cells. That is why I emphasized upon in the previous slide upon the differential diagnosis for the giant cells. Blood vessels will be showing plump endothelial cells, tenosynovitis, and rheumatoid nodules can also be seen. This is a good list for you people to reproduce. And this is the synovial membrane. You find that there are synovial giant cells. These should not be mistaken for Langerhans giant cells or Touton's giant cells. The classical picture of a rheumatoid arthritis, very wonderfully compiled and presented by this journal. I would like you people to kindly go through such ones. But what is important is, look at the very coarse surface over here. And you can imagine the trauma that it is going to cause, causing a crippling of the hands or any of the joints. So this is made out over here, and there is always a lateral deviation of the wrist. This is called the classical swan neck deformity, which is over there, and it is reflected in this action. All the other fingers are able to close, oppose, and lift an object, whereas this is standing separately apart. So thickening is over here, formation of pannus, deformity, etc. And in a sequence, you'll be finding there can be hyperplasia, inflammatory infiltrate, vascular proliferation, etc. Papillary projections can be over there. And finally, the formation of a pannus within. So if you have got any doubt, compare it with the normal synovium that is given over here. It is just 2 to 3 layers thick. And the junior postgraduate students will find it difficult to identify a synovial tissue. There might be small amounts of projections that are seen. And this is exactly the location, not within the joint. The synovial biopsy. For example, in a knee in arthritis, it is safe. It can be done for chronic inflammations. Synovial fluid can be aspirated. Granulomatous diseases such as tuberculosis can be diagnosed. So also pigmented bilionodular synovitis or amyloidosis. So this is a procedure. Obviously, it is very aseptic and advanced. Also, there can be a visualization of the picture within in a computer screen. I would like you people to kindly recollect the uses and the indications of arthroscopy and synovial biopsy. In the synovial fluid, what all can we see? It is a membrane, and then there are some nodules which are present within. They are all deposits of calcium, and there are some stains for calcium, namely alizarin red. That is why I am seeing a red color over here. This can happen whenever there is a degeneration and the joint is strengthened by means of prosthesis. Alizarin red, please remember for any of the pathological calcification, rheumatoid arthritis or tuberculosis or any other wear and tear. This is yet another example. I find that there can be a blackish discoloration caused by vancosa, which also can be an IX marker. And look at the precipitation of the calcium. This is the hydroxyapatite crystal deposition that is causing a destructive arthropathy. Here again, there is another condition called as synovial chondrometaplasia or secondary synovial chondroid metaplasia. So the joint is over here. Ankle is one. The knee joint is another classical example. But outside the joint spaces, there is the deposition or rather the metaplasia of the tissue with calcification and chondrocytes. That is why you find that there are radio-opaque bodies that are seen outside the bone and the joint space. Usually it is monoarticular. Knee or hip or bursae can be affected. Secondary to infection or trauma, you find osteocartilaginous bodies that are over there. Usually it affects the small bones and they might be present as floaters. The next couple of charts will be important, in which I mentioned what are the various indications. One is deposition diseases, such as any of the crystal arthropathies, amyloidosis, ochronosis, or hemarthrosis. Synovial. Then the next one is infectious arthritis, bacterial, mycobacterial, Lyme, Whipple's disease, and fungal. Whipple, I'll come. The next one is synovial tumors. So there are various lists of tumors such as synovial sarcoma and chondrosarcoma. Rarely there can be metastasis and lymphoma. Pigmented bilionodular synovitis is an exam slide for us. Histiocytic lesions can be sarcoidosis, any of the foreign bodies, or Erdheim Chester disease. Immunological can be rheumatoid arthritis. These 4 or 5 headings I would like you people to kindly memorize. Whereas this is a feature of the individual lesions. The lesions are given over here. What is the site? What is the presentation? And what other feature can be over there? Pigmented villonodular synovitis. For example, what is the site over here? How it can be present? And what are the features? It can be papillary with foamy histiocytes. Treatment is excision. I would like you people to kindly go through this entire chart. As also this. The other substances are amyloid, hemophilia, wherein there will be blood, and synovial sarcoma. These are some of the indications there. And the complete list can be obtained from Ackerman text. And the table on pathological changes continues. It is not for just the list. I would like you people to kindly analyze. It is extremely easy and simple. Amyloid, all of you know. There can be a primary amyloid and multiple myeloma. You people know. It can result in what is called a carpal tunnel syndrome, and it originates from transthyretin, a primary amyloidosis, AL amyloid. So also the other things. I would like you people to kindly go through this particular list along with the previous one. And see what is over here. There is a biopsy which is showing eosinophilic acellular material that is deposited. Even an experienced pathologist is likely to diagnose this as a PANS. But not everything is a PANS. This is a picture from the Australian Journal of Plastic Surgery. Credits to them. Surprisingly, I hope this is not a misfit, a Whipple's disease, a malabsorption disease from the GAT, in which I am finding lots of this foamy macrophages. Look at this one. You people can make out the foamy macrophages. But this is the endoscopic picture. Classically, it has been described as the bare skin rug appearance. And doing a periodic acid shift stain, it is positive. And this is the causative organism, namely Trophirema Whipple. This can also be causing a deposition within the synovial tissue. Though I could not get a good picture of it, have it in mind. It can affect the skin, it can affect the joints, it can affect the GAT. Remember, Whipple's disease has a differential diagnosis. In the synovium also, you will be finding foamy macrophages. Only thing is, it will be filled with bacteria, and antibiotic is the treatment. Acute on chronic synovitis, there can be acute inflammation. I hope you people can make out the neutrophils in this particular one. There are the neutrophils that is there. There is area of congestion. There is a granulation tissue. It can be formed in any kind of an acute inflammation or a bacterial sepsis. Also, there can be a chronic inflammation by spirochetes, such as Lyme's disease, and non-specific diseases. This is the pigmented villonodular synovitis. So the features are given over here. Go back to your text. It occurs in young adults. The knee and the other joints are affected. It is brownish yellow. There are multiple papillary projections which can be seen. There are foamy macrophages which can be seen, some of which are filled with hemosiderin pigmentation. They will be positive for histiocyte or synoviocyte markers. Excision is the rule, though when extensive, recurrence is possible. Initially, it is a granulation tissue, but you people can make out the brownish pigmentation over here, which is seen in this also. It is a classical examination slide for you people. And pigmented villonodular synovitis, multiple projections over here, and it goes into the joint space as well. Obviously, this is not an inflammation. I am able to find very aggressive spindle-shaped cells which are intervening, or sometimes they can be having an attempted storiform pattern. On the other hand, within the same tumor, there can be the proliferation of glands with marked pleomorphism, mitotic figures, increased nuclear cytoplasmic ratio. So this is classically a biphasic tumor, a synovial sarcoma, which is again shown over here. So there is a tumor consisting of spindle-shaped cells, and there is a glandular element also within. It is a very aggressive tumor which can be seen within the bone, in the joint space, or even outside. In the exam, they will not give you a history of tumor from the joint. They will say tumor from the upper limb or lower limb or so, because it will be too direct, and hence I would like you people to have it in mind. We have come to the end of this session as such, and I hope that you people will be able to recollect, interpret, and answer all the elements of synovial biopsy. And this is the way to say thank you in Russian.